The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. We've made it to the letter F in our Alphabet Soup series of clinical topics. I thought I'd stay in the same neighborhood as last week's episode and talk about Fournier Gangrene. I feel like this may be a thing that's more widely known now than in the past because of the SGLT2 inhibitor medications and their association with it. I'm always curious about the people that these things are named after. In fact, I was thinking of doing a whole series of episodes just about the people who common things that we deal with in medicine are named after common eponyms, I believe would be the correct term for that. On the American Family Physician podcast that I listened to most recently, one of the doctors on there was saying how he makes an effort not to say the eponym name for things and just call them the more technical name. And I can understand that for sure. But the history of medicine is pretty interesting. In general, it's kind of neat to know where things came from and how they came about. In this case, Fournier Gangrene is named after Jean-Alfred Fournier. He was a French dermatologist who specialized in studying venereal disease. Born in 1832 and died in 1914. It seems like his main thing was studying syphilis, actually. And according to his Wikipedia page, the study of congenital syphilis in particular was really his main contribution to medicine. He provided a description of that back in 1883. He was someone who consistently stressed the importance of syphilis being the cause of degenerative diseases over time. He actually founded an organization devoted to disseminating knowledge about syphilis in order to fight it. The organization is, obviously the name of the organization is in French, and I don't know how to speak French, so I'm kind of scared to try to pronounce it. I put it in Google Translate, and the translation that comes out is the French Society for Sanitary and Moral Prophylaxis. That's interesting. That makes me think there's probably a whole other layer to Dr. Fournier, or at least this society. So I looked that up separately, and here's the AI overview that is provided. Founded in 1901 by Dr. Fournier, primarily focused on addressing dangers of venereal diseases, particularly syphilis, and promoting measures for preventing their spread. Fournier saw the issue as not only a medical one, but also a social and moral problem that could threaten the French state. Oh, here we go. He advocated for open communication about reproductive health and the dangers of venereal diseases. That sounds reasonable. Education of adolescents and reproductive health sounds reasonable. The use of contemporary medicine in treating these diseases also sounds reasonable. Okay. They put out brochures with a combination of medical and social messages aimed at warning young people about the consequences of not protecting their sexual and reproductive health. They also advocated for national sex education. This was part of a larger social hygiene movement in France and in other countries in that time period, the late 19th and early 20th century, which aimed to address medical problems that were believed to have sort of a social background. So that includes not only venereal disease, but also tuberculosis, alcoholism, and mental illness. Fournier is considered a social hygienist, and those sorts of people emphasized strict self-discipline and often linked these problems to rapid urbanization. Some even supported eugenics. I knew we'd find it, advocating for measures to discourage or prevent certain groups from procreating. This does not say that Dr. Fournier was one of those eugenics people. There are other things in medicine named after Dr. Fournier. There's a thing called Fournier sign, which involves scarring on the mouth after the healing of lesions in congenital syphilis, as well as Fournier's tibia, which is described as fusiform thickening and anterior bowing of the tibia in congenital syphilis. How about that? I was thinking before I started all this that having a form of gangrene named after you is maybe not what most people would enjoy, but I guess having signs of syphilis named after you are not much better. So hats off to you, Dr. Fournier. Assuming you were not some kind of weird eugenics person, as far as I can tell, at least from Google searching, you were not. Thank you for your work. I should mention, however, that the condition we now know as Fournier gangrene actually was first described by a physician named Bourrienne back in 1764. So maybe we should call this Bourrienne gangrene instead. Okay, so what is this Fournier gangrene? I think we all have an idea of what gangrene means. When I think of that, I think of like a lot of dead, festering, infected, not healthy tissue. So Fournier gangrene is a part of a larger group of infections called necrotizing soft tissue infections, which can include fasciitis, myositis, and cellulitis. These things are all characterized by very extensive tissue destruction, systemic signs of toxicity, and high mortality rates. Going back to the whole history of medicine thing, back in the day, most things were named based on their clinical features because that's what they could see, right? That's what they were looking at in the patients in front of them. So that's why you kind of have all these different names for what is essentially the same thing, necrotizing infections of different parts of the body and different layers of tissue. The up-to-date article on this suggests that had things been named by surgical or pathologic findings, then there would not be as many separate terms for these things. Also, these kinds of infections are what you hear referred to in the popular media or the lay press as flesh-eating bacteria, right? If you're hearing that, that means necrotizing fasciitis, myositis, or cellulitis. Or it could potentially refer to clostridial infection or pyomyositis. So Fournier gangrene is a type of necrotizing fasciitis. So that means it involves deep, soft tissues. It results in destruction of the muscle fascia and the overlying subcutaneous fat. And when the infection spreads, it usually does so along the muscle fascia because the blood supply to that is pretty poor. A lot of times the muscle tissue actually does get spared from destruction because it does have a much better blood supply, of course. A lot of times the more superficial tissue, the overlying tissue, will appear unaffected, so that makes it a bit more challenging to diagnose these infections. One clue that can be helpful is that sometimes the overlying skin will become numb before there's actually any visible necrosis due to thrombosis of small blood vessels and destruction of superficial nerves in the subcutaneous tissue. Necrotizing fasciitis is further subdivided into polymicrobial, which is type 1, and monomicrobial, which is type 2. Fournier falls under the former classification, polymicrobial or type 1. This means it can be caused by aerobic and anaerobic bacteria, and normally you find at least one of each. So it's not like it can be caused by anaerobic or aerobic, it's usually both at the same time. And Fournier specifically is caused by E. coli, Klebsiella, Enterococcus, and then anaerobes, including Bacteroides, Fusobacterium, Clostridium, and anaerobic or microaerophilic Streptococcus. The other type of necrotizing fasciitis, the monomicrobial or type 2, is usually caused by Streptococcus, either group A strep or some other beta hemolytic strep. And it can also be caused by Staph aureus. Most of the type we're talking about, the polymicrobial necrotizing fasciitis, typically occurs in older adults, people with underlying comorbidities, the most important one of those being diabetes, especially when that's associated with peripheral vascular disease. I just think of diabetes as creating good conditions for infection. This is certainly not the most technical way to say this and may not strictly be correct in all circumstances, but to me, if the blood's sweeter, that means bacteria are going to flourish in it more. Same with the tissues, and then you throw in lack of blood supply, so the immune system can't get its defenses to where they're needed. You just set up a real good situation for bacteria and other infectious pathogens to flourish. So it kind of makes sense. Other risk factors associated with necrotizing infections are traumatic injuries that can either be like major penetrating trauma or smaller lacerations or blunt trauma. Anything that breaches the skin, specifically they list varicella, insect bites, and injection drug use. Any kind of recent surgery, especially anything involving the colon, the urinary tract, female reproductive tract, and also neonatal circumcision. That's a great way to start your life. Mucosal breaches caused by hemorrhoids, rectal fissures, or episiotomies, immunosuppression, cancer, obesity, alcoholism, and pretty much anything involving pregnancy, childbirth, pregnancy loss, or gynecologic procedures. Clinical findings in these infections, any kind of necrotizing thing, to me, the key thing to think about is that it progresses really fast. It usually shows up over a period of hours. So like when somebody comes into my office that has got a little wound from something and now 12 hours later it's taken over their entire extremity, that makes me want to be more aggressive because of the possibility of it being something like this than if that had developed over a longer period of time. So because it moves so fast, you can really progress pretty quickly to very extensive tissue destruction that can lead you to systemic toxicity, limb loss, or dying. So it's important to recognize this pretty quickly. Specific clinical signs include erythema without sharp margins, edema extending beyond the visible erythema, severe pain, fever, crepitus, and then skin signs like bullae, necrosis, or ecchymosis. Not unusual to see high fevers, tachycardia, hypotension. I feel like you could just kind of say septic shock there, right? You may notice that the subcutaneous tissue feels very indurated. This can lead to compartment syndrome if you get like crazy amounts of swelling. If they make it 3 to 5 days without treatment, you can start really seeing the skin breakdown and big bullae or just frank cutaneous gangrene. If this happens in a surgical wound, you usually see a whole lot of drainage. The subcutaneous tissue looks dusky and friable and pale. Subcutaneous gas is something that you think about with these types of infections, and that's something that you can actually see on a plain radiograph. So I always remember learning that if you get an x-ray of a part where there's some sort of wound and you can see gas bubbles in the subcutaneous tissue, that's a really bad sign and indicative of necrotizing type infection. So when this happens in the perineum, that's when it's called Fournier gangrene. Usually that happens because of a breach in the gastrointestinal or the urethral mucosa. It usually starts abruptly with severe pain and can spread pretty quickly to the abdominal wall and the gluteal muscles. It can involve the genitalia. More commonly, this affects men, but can certainly happen to women as well. I don't think there's any kind of specific lab testing for this. Of course, you're just going to see non-specific changes that you would expect with infection, inflammation. It's not recommended to use lab tests like that to try to help rule out a necrotizing infection. There is this tool that has been developed called the Laboratory Risk Indicator for Necrotizing Fasciitis, which takes into account the white blood cell count, hemoglobin, sodium, glucose, creatinine, and C-reactive protein. Evidently, it's demonstrated pretty variable sensitivity, so the up-to-date authors do not recommend using it as a tool to rule out necrotizing infections like these. Blood cultures are not super reliable, and also in the situation where you have multiple organisms, all the involved organisms may not show up in the blood culture, of course. So really, this is a clinical diagnosis, and really the only true way to diagnose it is with surgical exploration of the area. So if you do suspect you have Fournier or any kind of necrotizing infection, they really just need to go to surgery. We don't need to mess around too much with doing all of our other typical things to try to diagnose them. Sometimes this is pretty hard to spot. They may or may not have fever, especially if they've been taking NSAIDs for some reason. There may or may not be any obvious portal of entry for infection, and you really may not see any superficial cutaneous kind of signs until this has already progressed. Sometimes pain associated with this may be attributed to some other cause, especially if it was related to a traumatic injury or surgery. Of course, you can see swelling, you can see edema on an x-ray, but your first thought would not be to attribute that to a necrotizing infection. So if that gas is not present, then that makes it harder to see on imaging. And of course, a lot of the systemic symptoms that you see are just going to be vague, non-specific symptoms anyway. So kind of a tricky thing to diagnose sometimes. The earlier they can get into surgery to get debridement started, the better the outcome's going to be. They've demonstrated better survival rates with people who got taken to surgery within 24 hours after they came into the hospital. And it's even better if they can go to surgery within 6 hours of coming in. So quicker the better. This is not something that they have to take samples of and do pathology on during the surgery or biopsy first to know what's going on. It's based on the actual appearance of the tissue as they're operating and looking at it and exploring it. If we are looking for this with imaging, the best modality initially is the CT scan, and the finding of gas in the soft tissue is the most useful feature that might show up because that's very specific for a necrotizing soft tissue infection. MRI is not as useful because it's not as good at seeing the gas in the soft tissue, and it tends to overestimate the involvement of deep tissue. So it's a little bit harder to tell the difference between a more superficial necrotizing infection or a deeper infection. You might be able to use ultrasound for this. It hasn't really been studied a whole lot, but it is possible to see the gas in the tissue or localized abscesses, of course, with ultrasound. Of course, a bunch of imaging studies are going to potentially show you soft tissue swelling, which can be caused by a lot of things, so not super helpful when you're trying to look for a necrotizing infection. And then even if you do have visible clinical signs, it may still be tricky to differentiate this from just regular old cellulitis. Obviously, that's usually a slow-moving, localized thing that's not going to be associated with big systemic symptoms. There's pyoderma gangrenosum. It can be a little bit difficult to tell the difference between that and necrotizing fasciitis, which is unfortunate because if you take somebody with pyoderma gangrenosum to surgery early, that actually worsens the problem instead of making it better. That tends to be strongly associated with inflammatory bowel disease and progresses much slower than a necrotizing fasciitis kind of situation. It does not look like cellulitis at all and does not typically progress to any kind of systemic infection. These people are not generally as sick. This responds to immunosuppressive therapy, and it's not something that you treat with antibiotics either. When you think of gas in the tissue, you also think of gas gangrene, which is kind of similar but not the same. This is caused by gram-positive bacteria rather than the mix of aerobes and anaerobes that we see with what we're talking about. A lot of times that actually requires amputation. That's not something that can be fixed with just debridement. There's another condition called pyomyositis, which is where you get abscesses that form in the skeletal muscle. That's usually caused by Staph aureus. And again, more of a localized thing, not generally associated with crazy systemic symptoms. And that can usually be figured out by looking at imaging. They also list DVT as something that could be confused with this. Obviously, you think about swollen, painful, red extremities. But of course, if you see a swollen, painful, red leg, your first thought is going to be DVT, not necrotizing fasciitis. With Fournier, I guess you don't typically see DVTs presenting with redness and pain and swelling in the perineal area, so probably not as big of a deal for Fournier that we're talking about. Obviously, in addition to surgery, these folks are going to get antibiotics. Obviously, empiric treatment needs to be broad spectrum since we're suspecting multiple organisms are involved. So you'd want to have activity against gram-positive, gram-negative, and anaerobes. You can use a carbapenem by itself, or you can use pip/tazo plus something to cover MRSA like vancomycin plus clindamycin, which would cover the beta hemolytic strep and Staph aureus. They no longer recommend using ampicillin sulbactam or ticarcillin clavulinate due to drug resistance. If they can't take the carbapenem or pip/tazo, you can use either an aminoglycoside or a quinolone plus metronidazole. And obviously, you want to narrow that down as soon as you have any kind of culture results and sensitivities available. Of course, these people may get super sick if this infection is allowed to progress. So these are people who are going to require pretty aggressive supportive care. If you do have one of these infections that's caused by streptococcus, it can be helpful to give IVIG. Another thing that can potentially be done after surgical debridement is hyperbaric oxygen. Talking specifically about the association with Fournier and SGLT2 medications, looking at a study from the Annals of Internal Medicine from 2019, they found 55 cases of Fournier in people receiving SGLT2 inhibitors over a 6-year period between 2013 and 2019. Both genders, very wide age range, very wide range of onset of the Fournier symptoms from when they started the medication, 5 days up to 49 months. Can you really say it's associated with the medicine if it took 49 months to happen? I don't know. Although they mentioned that in comparison, if you look back between 1984 and 2019, they only found 19 cases of Fournier in patients taking other medications for diabetes. Of those 55 cases associated with SGLT2 inhibitor use, looks like they all got super sick. Some of them had DKA, some of them went into septic shock, some of them had acute kidney injury. 8 of them had to have fecal diversion surgery. 2 of them had to have a lower extremity amputated. 1 required a lower extremity bypass procedure because of gangrenous toes. 3 of them died. So far, it seems like the benefits of the SGLT2 inhibitors are way outweighing the risk of something like this happened. They have not put a black box warning on these medications, but Fournier is certainly listed as a potential major adverse effect of those medicines. The mortality rate of Fournier gangrene specifically is around 22 to 40%. With that type of necrotizing fasciitis in general, the polymicrobial type 1, it's around 21% overall. With the type 2 or monomicrobial forms of necrotizing fasciitis, it's 14 to 34%. Bad prognostic factors include white blood cell count over 30,000 with greater than 10% bands, serum creatinine greater than 2, age greater than 60, having streptococcal toxic shock syndrome, having a clostridial infection, delay in surgery for more than 24 hours, or a necrotizing infection involving head, neck, thorax, or abdomen, which is, like most of the body, I'm going to say. In my experience, I've seen this for sure one time. It was a really sad situation where the patient had schizophrenia and was off of their medicine, and they ended up sitting on the toilet for like 3 days straight. The story we heard was that they thought there were snakes everywhere, or they thought it was not safe to get off the toilet, and they sat there for so long I guess it totally cut off the circulation. They ended up with this terrible case of Fournier gangrene. I was working in PACU when I saw this, and the reason I saw it is because the poor patient had to keep coming back for surgery after surgery after surgery to just debride. And I don't know what the ultimate outcome was, but it didn't seem like it was going to end very well for that person. I may have run into one or two other patients that had it in the past, but I think that's the only time I have taken care of somebody that had it actively going on. I'm going to put this on my list of things that I especially don't want to get. Other things on that list include kidney stones, esophageal cancer, pancreatic cancer, melanoma, anything that involves major burns. So, all right, there you go. Short and sweet. Keep this in mind if you ever are looking at some kind of fast-moving infection involving the perineum, genitalia, especially in a diabetic patient, especially on someone taking SGLT2 inhibitor medication. Recognize it quickly and get them onto a surgeon so they can get fixed. I mean, repaired, not like fixed. You know what I mean. Okay, special thanks to our Patreon supporters. Thanks to all of you for listening. I hope you have a great week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.